Hello, I'm Dr. Wendy Chen, and today I'm going to be talking about take-home messages. So the purpose of this is really to just do a very brief and very fast overview of the topics that you've already heard about. This is really something that's meant to be listened to you after you've heard all the other talks, not beforehand. So we're going to run through all of the different cancers that you've heard about already. We're going to run through the epidemiology, the treatment and prognosis, and really just hit the high points for all of the cancers. I do not have any disclosures relevant to this presentation, so let's get started. We're going to start with breast cancer, which is my favorite cancer to talk about. And the risk factors, there are a lot of them, but the ones that come up most commonly are increasing age, obesity, a sedentary lifestyle, alcohol intake, and also genetics. Most importantly, the BRCA1 and 2 genes, they're only responsible for about 5 to 10% of all cancers, but they're associated with a quite high lifetime risk of breast and ovarian cancer, as you can see, slightly higher for BRCA1 than for BRCA2, but notably BRCA2 is associated with male breast cancers. In terms of prevention, tamoxifen, raloxifene, and the aromatase inhibitors have all been shown to decrease breast cancer risk, but none of them impact mortality, which is probably why they're not used as much as we thought they would be for prevention, even though they are effective. And screening, even though the individual guidelines will vary from the different societies, they all agree that women between the ages of 50 and 74 should get a mammogram at least every 1 to 2 years, with some societies recommending starting mammograms at either 40 or 45. In terms of adjuvant breast cancer therapy, what's the most important thing to remember about breast cancer is the subtype dictates the type of therapy. Mainly, is it ER positive or negative, or HER2 positive or negative? The particular groups that we use chemotherapy most commonly in are triple negative breast cancers, HER2 positive when given along with trastuzumab or other HER2-directed therapies, and then ER positive cancers who have an unfavorable gene expression profile, such as Oncotype DX testing. Hormonal therapy is widely used for estrogen-positive breast cancers, and that's because it decreases breast cancer mortality by a third, and it decreases contralateral breast cancer by half. Tamoxifen can be used both before and after the menopause and is combined with ovarian suppression sometimes, whereas the aromatase inhibitors are preferred for postmenopausal women. And the duration is either 5 to 10 years, depending upon someone's risk of breast cancer recurrence. And metastatic breast cancer is actually the same type of decision making. Is it estrogen positive or negative? Is it HER2 positive or negative? And as you can see going from the left, cancers that are estrogen positive and HER2 negative are treated with hormonal therapy plus a CDK4/6 inhibitor first. Whereas if it's estrogen positive and HER2 positive, we will often start with HER2 directed therapy with hormonal therapy. If it's estrogen negative and HER2 positive, it's chemotherapy along with HER2 directed therapy like pertuzumab and trastuzumab. Whereas if it's triple negative, it's just standard chemotherapy as well as some hopefully new novel targeted agents. Now moving on to lung cancer. The leading cause of cancer death in the United States at 136,000 per year. Smoking is obviously the #1 risk factor, and 80 to 90% of cases are in smokers, even though non-smokers do sometimes develop lung cancer. The risk of getting lung cancer is proportional to both the amount and duration of smoking. Quitting definitely helps and it reduces the risk, but it still does not return to baseline. About half of the people, unfortunately, do have metastatic disease at diagnosis, and survival is strongly correlated with stage. About 80% of cases are what's called non-small cell lung cancer. So let's talk about screening. There's about a 20 to 25 decrease in lung cancer mortality with screening. And so you really should be considering annual low-dose CT screening in these people who fit this category, ages 55 to 80, who have a greater than or equal to 30-pack-year smoking history, and they are either current smokers or had quit within the past 15 years. For follow-up of radiographic findings for screening, there are called what the lung RADS criteria, and that should be in your syllabus for the lung cancer talk. If, however, this was an incidental nodule that was seen on a scan that was performed for other reasons, the Fleischner criteria should be followed. And again, that should be in your syllabus in the lung cancer section. In terms of biopsy and staging, tissue is really critical. And that's because genomic analysis for lung cancer is incredibly important in terms of directing therapy. And so because of that, a core needle biopsy, when you get a larger amount of tissue, is strongly preferred to a fine needle aspiration. In addition, non-bone sites are strongly preferred. And that's because when you biopsy bone, it often has to be decalcified. And when that happens, the DNA can be denatured, and some of the immunohistochemistry assays can also be impacted. In terms of staging, they should definitely get a chest CT with contrast. A PET CT is also preferred to a bone scan given its increased sensitivity in detecting metastatic disease. In selected cases, a brain MRI is done, and for potentially resectable patients, a mediastinoscopy should be done as well. In terms of treatment, as you can see, it's really dictated by stage, with surgery for the earlier stages, but then for more extensive disease, either chemotherapy and radiation or multimodality approaches. And lung cancer is an area where the changes over the past 20 years have been absolutely amazing. And as you can see, in 2004, that is when the first targeted therapy of lung cancer was FDA approved, the ones that target the EGFR. What the pie chart shows you is that, unfortunately, the areas in the blue shows that many people with lung cancer do not have an actionable mutation. But the ones that do, which are the ones that are seen in the different colors, the targeted therapies can be extremely well tolerated and can also be associated with an improvement in overall survival. And it has truly transformed the natural history of metastatic lung cancer. The other thing that has done that is immunotherapy, which has been extremely successful in lung cancer. It can be used either by itself or in combination with a chemotherapy, and it can be a little bit confusing about figuring out who is the best person to use immunotherapy for, because there are different cutoffs for using the PD-L1 and PD-1 positivity. So moving on to genitourinary cancers. So prostate cancer, again, one of the most common cancers among men, although the numbers of death are actually smaller than some other cancers, and that's because many people with prostate cancer can be cured. The main risk factors are increasing age, a family history of prostate cancer, African American race, as well as some of them can be genetically related, BRCA1, BRCA2, and Lynch syndrome most prominently. Prostate cancer screening, as you can see, is a little bit confusing the way that breast cancer screening is, in that there are different associations that have slightly different guidelines. But in general, shared decision-making is always very important when we think about prostate cancer screening. And the other thing that's important to remember is that being African American and having family members who develop prostate cancer definitely put people in a higher risk category, and we think about screening differently for those people. So the grade and stage of prostate cancer is very important. And what's called the Gleason grade is determined by looking at the most prominent grade and then the next most prominent grade. So as shown in the middle, something listed as 4 plus 3 is considered a Gleason score of 7. And as you can see at the chart at the bottom of the table, someone with a Gleason score of 6 has a very low chance of dying of prostate cancer, less than 1%, whereas someone with a Gleason score of 8 to 10 has a 49% chance of prostate cancer mortality in 15 years. So the reason why it's so important to weigh toxicity is because of what I just showed you, that people with a very low risk prostate cancer can have excellent survival. So you do have to look at the toxicity of surgery, the surgical complications, erectile dysfunction, incontinence, radiation, again, urinary symptoms, bowel symptoms, and again, erectile dysfunction. And then androgen deprivation therapy, which can be associated with a large list of symptoms. And at the bottom, potentially an increased risk of cardiovascular disease. And so when you have something, a disease which can sometimes have very good survival, you do have to think carefully about what is the best risk benefit. And for every person, that's going to be different. And so that's why you can't really make universal recommendations for treatment the way that you can with some other types of cancers. And metastatic prostate cancer is again another area where there have been tremendous advances. So first line treatment of metastatic prostate cancer is always androgen deprivation therapy. And as it turns out, some prostate cancers are very responsive to androgen deprivation therapy and can be on it for a long period of time. But as you can see here, even after that stopped working, there are second line androgen blockers, there's bone targeted treatment, there's chemotherapy, there's PARP inhibitors, and there's also immunotherapy. So now moving on to bladder cancer. Again, a pretty common cancer with 81,000 cases per year, but what's very striking is the 3-to-1 male to female predominance, much more common among men. Median age is in the 70s. And again, the good news is not that many deaths per year because it's generally caught early. The risk factors are age, smoking is a very strong risk factor, occupational exposures. In the developing world, parasitic infections can be a problem, cyclophosphamide or arsenic, male gender, as I said, family history, and race. 50 to 60% of bladder cancers are just superficial disease, and the overwhelming majority, 90%, are either urothelial or transitional cell carcinomas. So most commonly it presents with either gross or microscopic hematuria, but it can also present with UTI-like symptoms such as frequency and dysuria. So it is important that if someone, especially a man, presents with UTI-like symptoms and does not appear to have a urinary tract infection, it is important to refer for cystoscopy and urine cytology if there is hematuria. The stage of bladder cancer is directly related to how far it invades through the bladder wall, as you can see with T1 being superficial. As is bolded when under T2, the path specimen must have muscularis propria. And what that means is they must have taken a deep enough biopsy because you need to know, did it invade the muscle? And if you didn't have any muscle in your biopsy, you actually don't know the answer to that. So it's very important to make sure that it was a sufficient specimen that was removed, and that, as you can see, T3 and T4 are even deeper levels of invasion. And the reason why this is important is, as you can see from the spectrum of bladder cancer, is that for non-muscle invasive, which is about 60% of them, they can be treated very easily with a transurethral resection, a TURBT, along with intravesicular chemotherapy, and these rarely metastasize. However, if you have a muscle invasive tumor, which is about 30% of the time, that can be treated with a radical cystectomy plus or minus chemotherapy. Or in certain selected cases, they are doing bladder preservation by using only chemoradiation therapy. A small number of these, however, can become metastatic, and then treatment of metastatic bladder cancer can be quite challenging. Now we'll move on to the gastrointestinal cancers. So now we'll move on to esophageal cancer, and the risk factors depend upon the histology. Squamous cell carcinomas are more strongly associated with alcohol, tobacco, and prior radiation. Adenocarcinomas, which are more common in the distal esophagus near the stomach, are more commonly associated with Barrett's, reflux, and obesity. Localized disease is treated with neoadjuvant chemoradiation. Metastatic disease, unfortunately, still has a pretty poor survival with a median survival of only 7 to 12 months. Palliative radiation is done sometimes. Palliative chemotherapy can be done. This is usually platinum based. Interestingly, some esophageal and gastric cancers are HER2 positive, and you can use trastuzumab or Herceptin for these cancers, but they unfortunately do not have quite as high a response rate as they do when we use it for breast cancer. And immunotherapy more recently has been used for later lines of treatment and does appear to have some activity. So moving on to gastric cancers, and as I said before, esophageal cancers near the stomach are often treated similarly to gastric cancers. The risk factors are H. pylori infection, salted meats, nitrates, lack of refrigeration, certain occupational exposures, and there are certain families that carry these E-cadherin mutations that are associated with an increased risk of gastric cancer. Localized disease is surgery plus or minus chemotherapy, plus or minus radiation. And again, palliative therapy for metastatic disease, again, a rather poor prognosis. Again, first-line chemotherapy, usually platinum-based. Trastuzumab can be used for HER2 positive, but not with quite the same high response rates as for breast cancer, and immunotherapy is used for later lines. For pancreatic cancer, the risk factors, again, can be genetic, but also diabetes, obesity, and tobacco use. Localized disease is unfortunately only about 15% of patients. For those patients, they're treated with surgery, sometimes with adjuvant chemo and RT, and about 15% of those can have longer-term survival, greater than 5 years. Locally advanced, just chemotherapy and radiation without surgery. And then metastatic disease, there is chemotherapy with some activity, but this chemotherapy is quite difficult, such as FOLFIRINOX or gemcitabine and nab-paclitaxel. So finally, colorectal cancer. We know a lot about risk factors for colorectal cancer. There's some things that increase risk, such as family history, inflammatory bowel disease, diabetes, smoking, obesity, and a Western diet. And then there are things that are associated with a decreased risk, such as screening, exercise, vitamin D, aspirin, nonsteroidals, and calcium. Hereditary colon cancer is only a small percentage of all colon cancers, about 5% of cases. The most common colon cancer genes are the FAP genes and the hereditary non-polyposis colorectal cancer or Lynch syndrome, although there are some other cancer, gene mutations also associated with colorectal cancer. The American Cancer Society guidelines for colorectal screening have been updated fairly recently, and although they still recommend routine screening starting at the age of 50, they do suggest now to consider screening at the age of 45, because for reasons that are not completely understood yet, the age of colon cancer diagnosis appears to be getting younger, and it does appear to be becoming more common among younger people. The options are all listed below. Any of them would be reasonable, although all of them listed with an asterisk. A colonoscopy should be done if those test results are positive. Colorectal cancer treatment for either the colon or the rectum are slightly different, but as you can see, are strongly related to the stage, and stage is also strongly related to survival, as can be seen in the column to the right, with 5-year survivals of greater than 90% for stage 1, but only 8 to 10% for stage 4. Now we're going to move on to the hematologic cancers. So myelodysplastic syndrome, not really a cancer, but can turn into a cancer, and is heterogeneous in presentation and also in its risk of progression. The main risk factors are age and prior chemotherapy or radiation. The most common presentation with cytopenias, with anemia being the most common, you have to have a bone marrow biopsy with karyotype in order to definitively make a diagnosis of myelodysplastic syndrome. And the prognosis is strongly related to what's called the IPSS, which is the International Prognostic Scoring System. And they look at a combination of 3 factors: the percent blasts, cytogenetics, and the number of cytopenias. And the treatments can range from just supportive care alone to disease-modifying agents such as azacitidine, decitabine, or lenalidomide. And the only thing that it can be treated with curative intent is an allogeneic stem cell transplant. But that obviously depends upon having a candidate who would be a good risk for an allogeneic stem cell transplant. Acute myeloid leukemia has similar risk factors, including age, prior chemotherapy and radiation, and also myelodysplastic syndrome can evolve into acute myeloid leukemia. The prognosis is strongly related to age. People who are older at the time of diagnosis have a much worse prognosis than people who are younger at the time of diagnosis. There are also different cytogenetic and mutation profiles, which are associated with both favorable and unfavorable things. These are often asked on the hematology oncology boards, but not as common for the internal medicine. The treatment is always induction chemotherapy if someone is fit, and that is generally anthracycline and cytarabine. The exception is if someone has the subtype known as APML, and in that is extremely sensitive to ATRA, which is all transretinoic acid, and arsenic plus or minus chemotherapy. Consolidation, when given with curative intent, is chemotherapy or an allogeneic transplant, depending upon the risk of the leukemia. Chronic myeloid leukemia is a myeloproliferative disorder, and this is defined by you have to have the Philadelphia chromosome with a translocation between chromosomes 9 and 22. CML commonly presents with leukocytosis and splenomegaly. And the natural history before the new treatments that we have for it was that someone was in chronic phase for a period of time, then went into accelerated phase, and then blast phase or a leukemic phase. However, the treatment, which is imatinib and other tyrosine kinase inhibitors that specifically target their translocation, the life expectancy now actually approaches that of age-matched population. So again, an example of an area where targeted therapy has truly transformed the landscape of a disease. Acute lymphoblastic leukemia is the rarest one that's seen among adults. It's the most common childhood cancer, but it represents only 15% of adult leukemias. In terms of prognosis, is again age, whether there's a Philadelphia chromosome or not, the cytogenetic and the molecular profile, and did someone have a high white count at diagnosis. The treatment is based upon pediatric regimens, and it is very intense. It's induction, followed by consolidation, followed by CNS prophylaxis. So that means either chemotherapy or radiation therapy to the brain, followed by maintenance therapy. Kids do really well with this. For adults, as you can imagine, it's a lot harder. And this is guided by the Philadelphia chromosome status in terms of the actual regimens. The relapse disease of ALL is really extremely poor prognosis. So there are some novel therapies, such as this antibody targeting CD19 and CD3, as well as antibody drug conjugates, and also CAR T-cell therapy is being used for relapse ALL. So multiple myeloma. So the diagnosis of multiple myeloma requires either more than 10% plasma cells in the bone marrow, or else a plasmacytoma. And most importantly, there also needs to be evidence of end organ damage. And that is either hypercalcemia, renal insufficiency, anemia, or bone lesions. The stage is determined by a combination of the serum beta-2 microglobulin and the serum albumin. And as you can see, median survival is strongly related to stage. Complications of multiple myeloma can make these patients very challenging to take care of. And as you can see, the list is long in terms of bone disease, hypercalcemia, hyperviscosity, infections, renal issues, cardiac issues, anemia, or neuropathy. And for multiple myeloma treatment, it's really bifurcated into, is this person a transplant candidate or not? with one arm for people who are not transplant candidates and another for people who are transplant candidates. They all commonly use dexamethasone, but then as you can see, there are variations on some of the other drugs. However, all of them receive bisphosphonates for bony disease, which helps prevent hypercalcemia, but also helps prevent skeletal-related complications. So the final group of diseases we're going to talk about are lymphomas. And so non-Hodgkin's lymphoma can be considered in three categories: indolent ones, such as follicular lymphoma; aggressive ones, such as the diffuse large B-cell lymphoma; and then highly aggressive ones, such as the Burkitt lymphoma. So even though I list those as aggressive and highly aggressive, interestingly, their response to chemotherapy is actually very curable, whereas the indolent lymphomas, even though they can survive many years untreated, they actually cannot easily be treated with curative intent. So the diagnosis of non-Hodgkin's lymphoma is usually with a lymph node, and it's really important, similar to when we talked about lung cancer when you need tissue, is you really want an excisional biopsy so that the architecture and you can get as much tissue as possible. Alternatively, a CT-guided needle biopsy is okay, but we really don't want to use fine needle aspiration. You send for pathology, but also importantly, immunohistochemistry and flow cytometry. And the workup includes a PET CT and a bone marrow biopsy. And so now we're going to move to Hodgkin's lymphoma. So as you can see, for stage 1 and 2 disease, chemo plus or minus radiation, because 85 to 90% can be cured with initial chemotherapy, radiation is actually being done less now than it used to be. For stage 3 and 4, chemotherapy is always required. The role of radiation therapy to sites of bulky disease are uncertain, and because of toxicities of radiation, people are trying to be more careful about it. And despite being stage 3 and 4, 75% of people can be cured with initial therapy. Thank you so much for, I know, what has been a whirlwind tour of take-home messages. And again, the purpose of this talk was really to consolidate what you've already heard. And all of the material that was presented, these slides, were all already covered in the preceding lectures. Thank you very much.